Okay, Dr. Himmler, if you want to just give yourself a quick introduction and put your deck into presentation mode, you can go ahead and begin.
Sure. Oh, that's not the right slide. Oh, there it goes. Okay. Sorry, I have to use the office that my job gives me, which is on the computer. Hi guys. My name is Amber Himmler. I am a first year trauma attending at Harbor UCLA in Los Angeles in the United States. Um, I am pretty newly getting involved in the Pan American. Have had some mentors during my research here, um, kind of on the kind of South American and Ecuador side of things. So I'm excited to, get to be more involved. I am going to go over a case that I had a couple of weeks ago, and excited to hear how you guys would handle it. So this was a trauma activation that came in. It was a 35-year-old female who presented to us as the highest level trauma activation with a stab wounds to the left neck, the left chest, and the epigastrium. On her primary survey, her airway was intact. She had bilateral breath sounds. Her vital signs can be seen here. She had a heart rate of 90, blood pressure of 113/69, had palpable pulses, and a GCS of 15. And on her secondary survey, she was found to have a stab wound to the left neck with a palpable thrill and audible bruit. She had the stab wound to the left chest and again the epigastrium without any evidence of peritonitis. We did get a chest x-ray on her in the trauma bay, which is seen here is rather unremarkable. At this point, I would ask the group, how would you all proceed with this patient with that information?
Dr. Untak, would you like to have a go at it?
Sure. So, the photo you showed has a stab wound in zone 2 on the right side of the neck. So to the left neck. So what is that? Are you sure? So there's a stab wound left neck and also
left neck and also the right neck. I'm sorry. It's
both
mostly
sides. Okay, two separate ones, right?
Yes.
And the audible bruit and the thrill on the left side. So those are signs of a serious injury. This one looks like she may be intubated already, but that's if the airway is stable, she has some at least moderate signs of a vascular injury. Sounds like an arterial injury on that side, and you did the chest X-ray, so I'm sure you have 2 peripheral IVs inserted, and I would add to what you did an ultrasound exam. So basically an EFAS, and also have a look at the neck, both sides of the neck, to look for the signs of a hematoma, arterial injury. But at that point, I think it would be reasonable. You have 2 options. You can go to the operating room for an exploration, especially if you see signs of a hematoma on ultrasound, to supplement the bruit and the thrill, or you can if there's no signs of peritoneal penetration or and there was no evidence of a pneumothorax, then you could potentially go to interventional radiology if the injury is limited to the carotid, or just basically an arterial injury on the left side, and or to rule out bilateral injuries, a subtle injury on the right side as well that might eventually need to be addressed. And because you have stab wounds on both sides, then if they're amenable to interventional radiology, if they're bilateral, and you can treat them both with minimal intervention, that would would be preferable. Generally, zone 2, you can proceed directly to the operating room if you have hard signs of an injury. So I'm guessing that you intubated the patient and you went to the OR possibly with a collar incision to be able to see both sides.
So this was a picture that I took in the OR. So I am skipping
Yeah.
ahead.
Yeah.
And
Okay, but Dr. Qasim may, I think he might want to comment.
I would love to. So when I look at this case, I look at three cavities. One in the neck, one in the chest, one in the abdomen. The first question I will ask myself would be, which one of these is going to kill the patient rapidly?
Mhm.
So I want to rule out the easiest, which will be the abdomen. I will do while you're doing a chest x-ray, you can also do a KUB of the abdomen to see if there's any free air. And at least I will rule out viscous injury. And also I would probably do a ultrasound like Dr. Untrak mentioned, especially of the abdomen, and also I will have a look at the pericardium and perhaps the chest as well to see if there is any lung slide. And these don't take very much of my time, and I would get this done very quickly. The most important thing in the management of this case would be, is the patient maintaining the airway, or is she in any danger of losing the airway? Because that becomes very critical in the management of this case, as far as I can see. And if I have any doubt, I would not hesitate to intubate the patient immediately. Then I would like to know whether there is blood pouring out of any of these taboons, and if there are, and there are known maneuvers that you can do. And of course, the, the, this type of injury is very famous in South Africa. They see this almost every day, I'm told, by my friend who works in South Africa. And they usually manage this, without going to the operating room quite successfully, I must say. And I would pay attention to that. So having determined the airway is being compromised, and if it is, then I would definitely intubate the patient. And the next thing I would like to know is this patient, does this patient require emergency surgery in the OR, or can I send the patient to the interventional radiologist? Or also, can I send the patient to the X-ray department, knowing going to the X-ray department in a case like this is the first sign the patient is going to die in the X-ray department? Don't do that unless you are absolutely sure the patient will be very stable in the X-ray department or in the CT scanner or something like that. And you want to avoid that as much as possible. So I think there are some decisions I need to make in the management of this patient, which involves going to the operating room, going to the CT scanner, or managing this conservatively for the time being till I get all the ducks in the row. Thank you.
Yes, so all things that we're certainly going through our heads as we were trying to sort this patient out. I will say, as far as airway, while she did have the hematoma and a thrill, her airway was not compromised. She was protecting her airway. She did not have any bright red blood pouring from her wound per se, but she did, like I said, have the thrill. But I think you all kind of hit on the head of the question of, does this patient belong in the OR, or do they belong in the CT scanner? And then also this question of where to go, which cavity is going to kill the patient. I think we have a KUB also that looked quite unremarkable. I did do a fast on the patient, and she had a negative pericardial fast, did not see evidence of a hemothorax. I will say I had not considered checking the carotid for with ultrasound. I think that's really an interesting idea that I hadn't thought of before. So I think that's great. Um, and I absolutely hear you about death beginning in CAT scan and being very cautious. I am very fortunate to be at a place that has a CAT scanner right next to the trauma bay. And so it is very accessible. Um, so while I think a lot of people would have probably gone straight to the operating room, we did end up scanning the patient. I think after some discussion, we were concerned with the size of the epigastric wound, that she could perhaps have some solid organ injury. And there was also concern that this patient was going to need heparin in the OR. So we wanted to have a better idea of possibly going in, which was kind of our rationale. So, and also now I have pretty pictures to show everyone. Um, so this is, I'm hoping this will work. Okay, let's see if it'll go. So this is the axials of her CT of the neck. Yeah. The other consideration, I think that I had previously mentioned, she had injury, she had stab wounds to both sides of the neck. So I think another question was, do we need to be on the right? Do we need to be on the left? The left had, or sorry, the right had had the hard signs of a vascular injury. Okay, here are the coronals, also just as impressive. Sorry, I may have cut off down there, but you all. Oh. And then we scanned her all the way through to see if there was any additional sign of injury, and we did not appreciate anything additional in her chest or in her abdomen. So with that, we're pretty confident that we would take her and just focus on the neck at this point. So you all, obviously, I would say probably everyone on this call has much more experience with this than I do. And I will say this was not a case that I was tackling by myself as a first year attending by any stretch of the imagination. So I think the choice of incision, first of all, like the cavity, are we in the neck? Are we in the chest? Are we in the belly was the first question. And then the second question was, like you all mentioned, a choice of a collar incision versus that anterior SCM incision. And then I guess my question to the group would be, how do you all, when you all are making these incisions, I am at a place that if for a common carotid, it's very reasonable where I am practicing for the trauma surgeon to go after that incision. But for us, when we're talking about the internal, for instance, we would certainly be getting vascular involved. You all who have much more experience than I do, how do you all think about your operative approach when you're going into when you have a patient that's presenting with carotid injuries?
So I'll go first on this time. Having ruled out there is essentially a benign abdomen, and I'm not so concerned that the patient may hemorrhage into the peritoneal cavity, die on the table, and I would pay attention to the neck and the chest. And essentially, in a case like this, I think I would like to start with the classical, the longitudinal incision that we do for carotid injury or vascular injury in the neck, which is along the border of the sternomastoid, and but have the chest prepped just in case that you
Yeah.
have, the upper part of the subclavian or one of the subclavian branches are bleeding. You may have access to that. So I would start with the classic um, carotid incision, and then I have to make a decision whether I need to go um, into the upper part of the chest. If it is, and I do not shy away from taking the middle third of the clavicle, because that's the easiest thing that I can do. I don't like to do the trapdoor incision because it takes too long, and also it is cumbersome, and I can easily do um, the clavicular incision and get access to the upper part of the subclavian and its branches if they are injured. Dr. Untrak?
Yeah, so I agree with that. I think the preferred incision is the anterior sternocleidomastoid longitudinal incision, especially if you have if the injury is limited to one side. And you have the benefit of the CT scan, but I'm still a little unclear about the CT. I saw what looked like a very full internal jugular vein on that side, if I'm reading it correctly, on the transverse section, and I didn't see anything that looked like a big hematoma on either side. My concern is that you have the thrill and the bruit and signs of a hematoma on the left side, although I'm a little yeah. So there you go. So that
So it's all sorry, everything is on the right. That's a mistake on my part. So I had bilateral, but the right is the one that had the injury.
no, but I mean the bruit and the thrill were on the right side, not the left
Yeah,
side.
correct. That's my
All right. Well, there you go. So because the left side looks pretty normal, the right side, and then on the coronal section, it looked like there was thrombosis and without contrast. So how did the radiologist? Is it look? Like right there. I guess that is extravasation. So if you're really convinced everything is on the right side, and then I would in this case I would make a longitudinal incision, because it looks like everything on the left side looks good. I don't even see any air in the soft tissues where the knife would have gone. It looks like there in that cut you can see a little bit where the knife might have gone through. Possibly, there looks like some air in the subcutaneous tissues, and then going through the platysma. The left side looks totally fine. So yeah, I agree with Dr. Qasim. I would just make a longitudinal incision on that side, and explore the great vessels. Yes.
And there's a little bit of
we have a question from one of the participants. He's asking, pre-surgically, did you determine the patient has an AV fistula in the neck?
So pre-surgically, we determined that the patient had a transection of the or extravasation, I should say, from the common carotid. I would say that that's what we were able to definitively see based on the CT scan, and that's how it was read by the radiologist, was active extravasation. They actually read it as from both the IJ and the right common carotid artery.
But what about the presence of bruit? What does that indicate?
I mean, I think that the patient probably did have some underlying fistula, but with the scan that we obtained, kind of the quick trauma scan, we didn't appreciate that, but I think that by physical exam, the patient certainly would have had evidence of a fistula, a traumatic AV fistula.
Oh, good. Thank you.
And also in that section right there, you can see bubbles of gas on both sides. So in fact, right to left. So I think so. It needs to, you need to deal with the vascular injury, but also do a very good exploration, ruling out aerodigestive injury, although you could get that just from introducing air with the stab wounds, but nice films. And you can see the big hematoma. Mostly, yeah, there you can see both sides. It looks like some subcutaneous hemorrhage and the gas on the left side, but mostly on the right side.
And sorry, I'm talking to you all from work, and the computers are a little bit slow, so I do apologize. But yeah, so if I slow down, like you're mentioning, you can see the air on both sides, hematoma, but certainly our biggest injury area of concern being on the patient's right side. Okay. So so operative approach, again, you guys have all certainly probably done this more than I have. So we tucked the patient's arm, positioned her head to the right side, and then we did go with that longitudinal incision along the anterior border of the sternocleidomastoid. As soon as we went to reflect the border of the sternocleidomastoid, we did release the very large hematoma that had previously been contained in her neck. And we were ultimately able to identify a transection to both the right IJ and then also to the common carotid.
Oh.
So considerations for repair. So I guess for the group, when you all have these types of injuries, as far as the IJ goes, obviously that's lower stakes than the arterial injury, but do you all typically opt to repair or to ligate if it's just a one-sided injury?
By and large, most surgeons will ligate it,
Ligate.
but there are some brave souls which may want to repair this, but I think 99.9% of the surgeons will ligate it because that's what the history dictates to us.
I think, but if it became a bilateral injury, that certainly would change the calculation, I imagine, but I imagine would be quite a rare presentation. We also went ahead and ligated the IJ in this case.
I was going to just comment. I would add that I would ask, first of all, was there back bleeding from the efferent side, from the carotid, from the in other words, if you took the clamps off, you had proximal distal control, but if you remove the distal control, was there back bleeding?
Yeah, so so that was the venous portion. So on the arterial portion, yeah, so we got around with proximal and distal control. It was in zone 2. So this was common carotid, so the bifurcation was not at all involved. There was vigorous back bleeding
Yes.
from the carotid, judging after once my the hematoma was released.
Okay, and if you control the external carotid, with it still back bleeding, in other words, flow across the circle of Willis?
Yes.
Yeah. So yeah. So I think that clinches it. Then, in that case, then the patient was neurologically intact. So that's a very, very good sign that she still had, the hematoma probably, tamponaded a lot of the blood loss, so it didn't expand very much. There was no blood coming out of the stab wound, and so she had excellent flow. And in that case, certainly, you can go ahead and you should ligate. The other problem you get into is if there was no back bleeding, and then you go ahead and ligate, then you might convert, depending on how long the injury has been there before you encounter it in the OR, but then you would convert an ischemic stroke to a hemorrhagic one, But in this case, a young woman, neurologically intact, and signs that flow is preserved throughout the time of the stab till you got to the OR, then I agree with Dr. Kinnison to just ligate, and then you're done. Then you can do the rest of the exploration and finish up.
I also had the benefit of the CT scan, which also was another demonstration that my circle of Willis was intact. And so it is interesting to kind of think about going through this case without that information. I think it would have certainly made it much more challenging. And
Could I
I'm so sorry. Hello.
could I chime in one other thing? If you are doing a lot of this carotid surgery in this particular OR, which some institution, we do a lot of these, and it doesn't take very long to measure a stump pressure. You have a transected carotid, and you have the proximal and distal. You can easily insert a catheter into the proximal part and do a stump pressure. If the stump pressure is over 40 millimeter, then you are reasonably reassured the patient is perfusing through the circular villus, and then you can take your time to do whatever you are anticipating to do. Something that keeps in mind if you don't have the luxury of the CT scanner like you did.
And then if you're finding yourself in the OR and your stump pressure is low, how do you approach that?
Then you have to shunt it. You have to do a quick shunt. You put the indwelling shunt.
Your shunt.
And,
shunt. Okay, that was my question.
And then think about how you're going to bridge the gap. What methodology that you're going to use to bridge the gap while the stump is the flow is maintained in the shunt, in the argyle shunt. All these have to be done very quickly. You must have plan A, plan B in mind. If one fails, the other one comes in very quickly.
For this particular patient, if I go back kind of to her picture, we were very fortunate that this was a stab wound, not a gunshot wound, and so we were able to really just debride back the edges of the carotid that was transected, and we were able to bring it together primarily. I know if we're talking about ballistic injuries and other things that isn't always the case. I haven't yet had a case that I've required an interposition graft or a need to do patch angioplasty. I guess have you all encountered that situation? And if you do, what vein do you tend to use for your conduit? And how do you all approach those situations when it doesn't come together well for a primary repair?
Dr. Himmler?
Yeah, so you mean for the common carotid?
Yeah.
Yeah, you can ligate if it's especially just one side. You just go ahead and ligate it. That's okay. There's no problem with that. And I've had on occasion injuries to the internal carotid, not carotid, the jugular vein that were easily repaired primarily, and I did that. But also, you worry about thrombosis afterwards, that they thrombose anyway. And if it's just limited to the carotid and not the subclavian, I think you can go ahead and ligate it with impunity. In this case, there'd be enough, and it's just limited to one side. I think that's okay to do. Now, if there was an injury on the other side, you'd have to repair one and repair the one that's most likely to succeed. But as far as conduit, I don't know of taking a vein conduit to repair the jugular. It's not something that I've seen.
Oh, I think we're talking about the carotid artery.
Oh, the carotid. Okay, yeah, there it's a clean. If it's clean, you can, and you can't do a primary repair.
We ligated the vein and we primaried the artery.
Yes. Okay. Right. Oh, you're talking about the artery. Yeah. For that, you can take the proximal or the distal, in other words, up near the groin, the large segment of saphenous vein, or I imagine that many people would use a small length of Gore-Tex for that if you just needed to, for this case where there's no contamination, and that would work well. The other thing you can do is depending on, so it's common carotid, if you could, if it would set itself up for like a carotid subclavian anastomosis, that's sometimes that you do for stenosis of the innominate artery, or the proximal carotid stenosis. If that were easy, in this case, it looks like it'd be a long haul. If you couldn't do a primary repair, it'd be just as difficult to do a carotid. It'd be more difficult to do a carotid subclavian anastomosis. So I would probably, in this case, just take a segment of a small piece of Gore-Tex. So you wouldn't need more than maybe a centimeter or two.
Okay, yeah, that's I was thinking, in my backup plan, thoughts about saphenous in her, and I was concerned that I thought the saphenous might be a little too small. But I know it does dilate up some once you resect it and dilate it up with the olive tip. But yeah, I think, yeah, Gore-Tex, and I suppose it's a very high, it's obviously a very high pressure artery, so perhaps a lower risk of thrombosing down the line.
Can I chime in?
Please.
So, having seen both use of the saphenous vein as well as an artificial graft, I have seen one patient who had a saphenous vein interposition graft put in, and then 10 days later, the anastomosis blew, and the patient was hemorrhaging.
From what graft? I'm so sorry.
It's saphenous vein graft.
Ah,
It
okay.
was an interposition saphenous vein graft. One patient only. I don't know. This particular institution, they have done hundreds of these, and ever since then, ever since I saw that, I have become, once bitten, twice shy. I try not to do that, and I would probably use a ring Gore-Tex graft and get this done and go to bed quickly.
Although, if I can say, there's a lot of experience using saphenous vein patches, for carotid. Yeah. So, yeah. So in general, it works. Why the patch should work, but not the graft, and it's. But I think most people in this case, if would use a Gore-Tex interposition, but in this case it's moot because you don't need to you did a repair anyway. You say in this case you did a primary end anastomosis, but you can ligating would have been perfectly acceptable here when the patient wouldn't have known the difference.
Fair. What would you do in the case of a concomitant aerodigestive injury? You would ligate?
Yeah. If you had contamination, and certainly in this case, if you had very brisk back bleeding through the internal carotid artery, so in other words, you occlude the external carotid, you still get this brisk back bleeding, and the patient had an aerodigestive injury, then that would make me more prone to ligate the vessel, and then seeing how the patient is when she wakes up, wake her up in the OR and be sure she's neurologically intact, just to be sure, and have drains and do whatever you need to for the aerodigestive injury, and then avoid lengthening the operation. Regardless of what you do, if you can they would say put vein and don't put graft in, but that's going to lengthen the operation. You have to go ahead and prep the leg if you haven't already. Take the vein, do 2 anastomoses. Be sure it stays patent, and then you still have to worry about occlusion of the graft, everything in here. It's better to avoid that. Anyway, Dr. Casso, I think he would comment on this, this hypothetical.
I think when you have two injuries, when you have a carotid injury plus aerodigestive injuries, and if there is a brisk back bleeding like Dr. Untrat said, I think you just go ahead and ligate it with impunity and hope for the best. The patient does not stroke out, and then go ahead and do further dissection and repair the esophageal injury, either with a buttress of one of the strap muscles that's available, and leave an NG tube and a drain to allow this to heal, because that particular injury will kill the patient, and the one from the carotid will give the patient a stroke. So both of them are bad outcomes, and you want to avoid both of them, so you do your best. If you have the time luxury, you have plenty of time available, and then quickly, put in whatever conduit you want to put in, preferably a vein graft of the carotid, and then go ahead and tackle the esophageal injury at the same sitting, and make sure that you drain this area adequately, and hope for the best.
I did also want to ask for injuries like this. I know you all mentioned Gore-Tex. Do you all have any experience, or do you ever use cryovein? Especially if there's concern for an infected field?
There are so many other materials that are coming on board now, and you have chemically treated conduits that you can use, and the substance that you mentioned is yet another alternative. I think it all depends on what your institution has, because these are very expensive stuff to hold on in the operating room for long-term use, and also your personal experience in using these materials.
Yeah, I don't have any experience with cryovein. What is it? Just cadaver vein that's been frozen?
Yeah.
And so what? So then what happens? Does the vein, does the endothelium and then the muscle, is it just sort of like a collagen scaffold that gets repopulated by the patient's endothelium?
I believe so, yes. I'm not sure that there's any data that shows that it's any better than PTFE. I have not personally used it, but I know some of our vascular colleagues will use it in bypasses and things like that. And kind of just wondering about different alternatives. Say, there was a concern that this patient was having a stroke with ligation or wasn't going to tolerate ligation, and you had an infected field, kind of like we were saying, plans B, C, D.
So where do they use that the cryovein? What for extremities, or where do they use it?
I've only seen it used in extremities. So I've seen it used on I saw it used on a brachial that was like a mangled extremity brachial, and I had seen it once used for femoral.
But why didn't they just use autologous vein?
In the brachial, the patient had a mangled upper extremity and injuries to the bilateral lower extremities, making the saphenous not accessible.
Yes.
The femoral, I do not remember. So it was quite extenuating circumstances.
Yeah. What I would consider in this case, if you did have a patient, for example, that there really was an occult solid organ injury or stab wound and getting hypotensive, and you did have aerodigestive injury, this is a very considerate assailant in this. I'm telling you, really, he really had the junior attendings in mind here. He figured that, okay, I'm gonna, it's whatever. But if you did have a case where there was laceration of the trachea, esophagus, and also the patient suddenly gets hypotensive and the belly's distending, and also there was it was backflow, but it got really piddly, and you're confident the patient didn't have a stroke, but is in danger of having one. I would consider just putting some drains there, putting in a shunt, basically damage control, and then go ahead and open the abdomen, take care of that, and then see how the patient is at the end of that part, whether you need to, go back to the ICU for 8 or 12 hours or just deal definitively with the neck. But I think if you put a shunt in and you watch it, if you have like a Javid shunt, you can sort of have a part of it that you can examine to be sure it's patent and functioning. If you put an Argyle shunt, you could query it with ultrasound, but I think that would probably stay patent for a few hours, for the time you would need to do damage control. And that's what I would consider, putting in this, whether if the patient needs to have blood flow restored right away, just put a shunt in, even if you can do a reconstruction, so you can take your time, get the vein or get the conduit, and go ahead and deal with it. But in this case, you have a very nice, clean situation. You can take your time to think about it, and then I think in this case, as you said, a primary repair would have worked fine.
Now, remember that when you are dealing with a case where time is of essence, so it is acceptable for you to shunt it and then go and do whatever you want to do and then come back some other day to deal with it. One other shunt that you guys have not mentioned is Inahara shunt. Dr. Inahara was a surgeon at St. Vincent's Hospital in Portland, Oregon, and he has a shunt with a side arm through which you can either heparinize the patient or put dye through it to examine the patency of the shunt, and it can be left there for 3 days, and then you can go back and shunt the patient and do whatever you want to do, and then you can go back 3 days or 2 days, 3 days later, and you can put an interposition graft.
Yeah, I think, and also, so is it any shunt you can have about 2 or 3 days, Dr. Kassan, before you have to go back?
I think this particular shunt, Dr. Inahara has been using it for a number of years, and he usually goes back on the 3rd day.
Yeah.
Leaves the shunt in, heparinize it through the side arm, and then goes back 3 days later and put an interposition Gotex graft. That's what I have seen him use.
Yeah, well, what if you didn't have an Inahara shunt and you put an Argyle shunt in, and it was working in the old, what, sorry?
I think you have to go back much sooner than that, because you wouldn't have the luxury of infusing directly into the shunt heparinized solution, because there is no sidearm available for Argyle.
Yes. Yeah, yes, but you can still monitor flow sonographically. Right. You would have enough time to stabilize the patient and then go back with the clean instruments, and after having rinsed out and done the primary, in other words, damage control with maybe 12 hours. Okay, yeah.
That is correct.
But I guess LA, you've got some very considerate assailants there. They've read the books.
They read the books, thank goodness for me. They had some mercy on me in my first 6 months out. So we did check the esophagus and trachea, so there was no actual aerodigestive injury, just the transection of the common carotid and the IJ. So again, we went ahead with our primary repair. As far as the decision kind of to shunt, not to shunt, we had talked about it. I think we had good back bleeding. I think we were able to debride everything back and anastomose very quickly. I think if we didn't have that knowledge already that she had an intact circumflex and also know that she had an intact neurologic exam, perhaps that would have changed the calculation. So it sounds like most of you all would shunt routinely for a case like this, or would not. Okay.
No, I would do it in this case. Sorry.
Not routinely, no.
Not routinely. Okay.
Yeah, because even in this case, doing the repair was kind of an option. I think that's reasonable that to do a repair. So where she gets older and she has a problem with the left carotid, a plaque there, at least she still had, she's got two and not
Sure.
totally living on. But this was totally optional, wasn't it, to go ahead and do the repair? You could have just ligated.
You could have
Yeah.
ligated it.
Yeah, so because there was an option to just ligate, you can ligate or clamping, for the 20 minutes it took you to sew the two ends together. But what was it? How the decision? You say you brought the vascular surgeons in. What was their?
Oh, no, we didn't bring the vascular surgeons
Oh, you
in.
did. Okay. Well, what was your rationale? If you can, this is a case where it's perfectly reasonable to ligate. But what was your thought process about doing the repair?
I think the fact that the edges were so clean, it came together very easily with not much in the way of mobilization. She had very good back bleeding, and so it kind of was, certainly ligating it would have been a little bit easier, but I think it was kind of like you said, a very considerate assailant and right there in front of us. And like the patient was only 35, so we don't know what her future will hold, and if it's easy to do, it seemed like it made the most sense.
Yeah, and I think that that's certainly a good choice. If she was unstable and other things weren't going well, as she had, you can see, saliva coming out, and even with saliva, you can repair it, a primary repair. But if you needed to get her out of the OR, you could, either ligate or leave a shunt and then consider coming back later. But I think that's perfectly reasonable what you did. And it's nice to know that either choice is good, and it looks like a beautiful repair. It's a shame you had to close the neck to cover it up. I mean, it's just beautiful.
Thank you. All right, and then we finished the case, and the patient became difficult to ventilate, and she dropped her blood pressure for the first time. And in spite of my attempts to get a CT scan, she ended up with a massive hemothorax on the left side after being heparinized, which was fortunately recognized before we left the operating room. And her hemothorax resolved nicely with a chest tube. She had a very minimal hemothorax on the initial CT scan. So I suppose maybe a lesson that I feel like my thought process in getting the CT scan in the first place was to try to foresee some bleeding complications, and I still ended up kind of experiencing one, even though I had kind of written off the chest at the beginning of the case. But post-operative consideration. So as far as long-term follow-up for patients that where you all repair injuries, it's a decision for anticoagulation or antiplatelet agents. Our practice here, my practice, I think in most of the places I've trained has been mostly an antiplatelet agent, so just a baby aspirin. I think it does remain a bit unclear to me how long people are remaining on aspirin. I know a lot of our patients don't necessarily follow up. And then do you all, if you, in cases like this, do you all routinely order any kind of duplex imaging on these patients as an outpatient, or do you follow these anastomoses?
Dr. Qasim, do you want to go ahead? Or he's not there. Anyway, I would certainly follow up. Get her to follow up, and depending on how long she was in the hospital, and you thought that she wasn't going to, the sort of patient that you'd never see again, I would have a look afterwards before she went home after a couple of days, to be sure there's adequate flow. And I would ask the vascular guys. I think it's perfectly benign for somebody to take aspirin. If you give her 30 baby aspirins, take one a day, I think they'll probably do it until, try to get them to come back. But I would see what the vascular people said. In this case, if it's just a nice case where you have a lot of redundancy here. If it did occlude, and I don't see why it would, an arterial, that kind of repair with high pressure flow.
Sure.
Uh, it's unlikely, but if it did, there would still be the flow from the external to the internal carotid would keep the clot from propagating more distally. And then also she would have, what'll bring her back is if she gets symptoms. If suddenly, she can't move her left side or she sees something wrong, she'll be back just as quickly as she came the first time. But I would say, I would ask the vascular guy, I would just run it by them just to be, just to see what they thought, even if I thought I knew the answer. And, and then I'm sure you looked it up to see what the recommendations are. So you can tell us what. I haven't looked that up in a while. The other thing I would have done in this case, just as a pre-postoperative considerations before leaving the OR, I would have explored that abdominal wound just to see, did it penetrate the peritoneal cavity?
I did a diagnostic laparoscopy and it was negative.
Okay, and that's the other thing I would have done. Yeah, it just slip a scope in, just look, and there was no penetration.
There was no penetration. So
right.
I
Yeah, that's the other good thing to do. Just right at the end, take 5 minutes, put the scope and look around, and everything's good. Right. Okay.
Yes, and I did. So I did discuss this case with our vascular colleagues, and I ordered a duplex ultrasound to follow just one time after as in the outpatient setting, and it was unremarkable. They had asked the patient, they recommended a month of aspirin, and this patient actually has followed up pretty routinely. She unfortunately was a victim of domestic violence and is now safe and doing well and on the road to recovery.
She have any? You must have some kids also, right?
2 kids, yeah.
Yeah. So the kids were with her at the time.
Yeah, one of them called 911.
And
Like,
her
very dramatic.
Was her assailant the father of the children?
He was.
Yeah. So I guess he's got to go through court. I don't know. I assume that means he would lose custody and whatever and keep
I
away.
would hope so.
Yeah, certainly. So, okay. Oh, there you go. That's actually the more serious decision, the more serious intervention right there for sure.
Absolutely.
Good work.
Any other questions, concerns about this case?
Great, terrific case that goes through all the considerations, and so the other side, did you try to sort of go subplatismally to run your finger there? Because there was the gas there, and
there was gas there. I checked, so I looked at the esophagus and the trachea. I didn't expose the carotid sheath on the other side.
Yeah.
And kind of exploring, I did locally explore that wound, and it didn't look like it truly violated the platysma.
Right, and if there was any concern, you could have post-op, or or maybe if you wanted to just avoid a return, you could slip a scope down, a bronchoscope and an esophagoscope, have a look, but just in the cervical esophagus and trachea. But I think that's reasonable. That it seemed like everything was limited to the right side. So really great case, and all the considerations. And I think it left any longer, she might have suffered trouble with the airways. So it's good that you took her to CT scan, but attended, not sort of left alone. And, ready to deal with. And you have people that can intubate in the trauma bay, right? You have do it yourself, or you have a CRNA or whatever. But really great case.
Thank you all very much.
Yes, and great for a first-year attending, if not a senior fellow. So very good. Do you have residents and fellows there in trauma? Sorry, residents. Okay, so you had residents with you, right?
I do. I have residents with me.
Okay, very, very good.
Yeah. All right. Thank you all very much.
Thanks, Dr. Himmler. Everyone have a great day.
Bye-bye.